Hi, my name is Liz Means, and I'm the Executive Director of A Way Out. And this is our final session for our 2020 virtual conference. And this is a panel discussion. And I want to thank everybody who's been attending or who's here with us today. We are really grateful to be doing this conference virtually. We haven't missed a beat in conferences in the last 5 years. And due to COVID, as you know, everything is different this year. So we've gone virtual, and we're really thankful that we haven't missed a conference, and we can still get some of this great information out to you. The panelists and the speakers and presenters are the ones who presented this week. Dr. Mike Barnes, Dr. Judy Grissel, and Raquel Lerner, all three did incredible presentations. Raquel just finished hers, so we will start with a question regarding her presentation. But I would like to thank our sponsors because they are the ones who helped make this possible. The production, all the back scenes were helped with by sponsorship of the A Way Out conference. We're very grateful to these entities. They're excellent programs. Without further ado, I'd like to introduce our board chairman, Mike Connolly. Oh, one reminder is to ask questions in the private comment section. Anything that you have questions about the last three presentations, they can get answered right now. So great. So Mike, our fearless chairman, is going to help moderate this with me. Mike.
Yes. Hi, Liz. Thanks for another different one, but a great year, 5th year of our conferences, and great content as always. It'll be interesting to have this roundtable discussion to wrap things up, but it's been a pleasure to watch as always. I wish we were in person at the Jerome or at the Institute, but considering the circumstances we're under, I think it's been a really wonderful year again.
Oh, great. Well, if you are joining for the first time, I do want to let the viewers know that we are a nonprofit. And we are dedicated to helping individuals and families who are in crisis with drugs and alcohol. You know, we support scholarships to help people get to treatment, and then we have lasting recovery support for a year or more. And we provide free counseling to family members. We have an alumni program, a peer support program, clinical program, and all of this is at no cost for those who are really underserved in the Western Slope communities in Garfield, Eagle, and Pitkin counties. Without further ado, again, I'd like to introduce our three panelists. And here they are. We have Dr. Barnes, who...
Hi, Liz.
Hi. Who did the presentation on Tuesday. He will talk in depth about families. We have Dr. Judy Grissel, who's at Bucknell University, and she is a neuropsychologist. Is that the correct phrase?
Probably not. I'm a behavioral neuroscientist. Neuropsychologists work with humans, and I primarily work with non-human animals to understand addiction.
Interesting. Okay, thank you for that clarification. And then we have Raquel Lerner, and she is associated nationally with all of her work on families, youth, addiction, narcissism. And each of you, if you could explain a little bit more about what you do before we start, that would be great.
So I'm the Chief Clinical Officer at the Foundry Treatment Center in Steamboat Springs, Colorado. And my areas of research and my areas of expertise are in trauma, addiction, and family systems. And so I have the good fortune of speaking a lot around the country on those issues and on trauma-integrated addiction treatment.
Terrific.
And I'm a recovering addict who hit bottom right about my 23rd birthday and decided to become a neuroscientist to cure addiction, and haven't quite gotten there yet, but I do research in pharmacology and genetics. And I recently wrote a book trying to connect the neuroscience of addiction, so what the scientific field understands is going on in the brains of people like me before and during and after an addiction, and with my own experience and other people's experience as either substance abusers or people in recovery.
Thank you. Raquel.
Hi, I am the senior clinical supervisor for a treatment center in Antigua called Crossroads. It's and my background is in family systems. I have been in. Some people call me a pioneer, which makes me feel really old, like a grandma. I have been instrumental years ago in the adult children of alcoholics field, and a little like, a little bit in my history too. I am an adult child of an alcoholic, and my mother is in recovery, by the way, at 95 for that. And my expertise is in family and relationship and couples issues. My job in Crossroads. Sorry, that was probably Crossroads calling. Anyway, it's in family systems and family healing.
Terrific. Well, we are so grateful to have all three of you here today. Our audience has a few questions, and Mike, can you take the first question?
Sure. This is from Facebook user. What are your thoughts about narcissism being taken out of the DSM?
Well, I guess that's directed to me, but I'd love to hear your comments too. There hasn't been enough appropriate research done on this condition. And I think I mentioned towards the beginning, typically the research has been done on men. We all know that there are narcissistic tendencies and narcissists in women. And we don't know enough about the mirror narcissist. Typically, it's been focused on the aggressive, the bullying, the grandiosity, but there's also that covert narcissism that has to do with more being a victim and the seething, the underlying anger, and I think once there is more research, I think it may be included again. So I think the way it was stated in the DSM, I think it was appropriate to omit it this time. And the narcissists and I hope it's going to get back in.
Terrific.
Even though it seems like I wouldn't know much about this, I do, because I study complex traits and mental illness, substance use disorders, and other mental illnesses and the genetics of that. I'm pretty aware of how the National Institute of Mental Health views these things. And I'm just commenting from the outside, but kind of to agree with Raquel that we don't really know what it is. We don't even know what exactly depression is or what exactly addiction is. We know you're diabetic if you have certain insulin, issues that we could measure, or you have high blood pressure or cancer, because we can see the cells and we can look at the data. But with behavioral traits like narcissism or other psychological disorders, we're making guesses based on, a list of symptomology, kind of like a Chinese menu or something. If you have 2 of these and 1 of these and 3 of these. So the fact that it changes all the time as an outsider is just accounted for by the truth that we have a hard time understanding these. Human behavior is so complex. And what's pathological at one time, might not be at the next, or vice versa. So I agree with Raquel that more research and better understanding from the behavioral perspective, but also from the underlying genetic architecture and neural contributions is really necessary.
Great. Mike, we can't hear you.
Barnes or Mike Conley?
Mike Barnes, sorry, that was confusing. Mike, we still can't hear you.
Can you hear me now?
Yes.
Okay. So I'm curious the thoughts of the other panelists on kind of a developmental trauma framework, and that, when I read research on personality disorders, they always sort of talk about someone with post-traumatic stress disorder or not. And one of the things that we find is that 30% of our population have an actual PTSD diagnosis, but upward 50 to sometimes 60% have more of what I would consider developmental trauma struggles. And I was just really curious what the others would think of what is the trauma foundation, or what are your thoughts on that?
The trauma.
That's my thought. Yeah, my thought is that most personality disorders are based on family trauma, and that it was very appropriate to take narcissism out of the DSM. It's time that we put developmental trauma into the DSM, as we have in the ICD-9 or ICD-10.
I think narcissism is a result of developmental trauma. I mean, and I did speak to that. And the research I did for my book, they talk about the rapprochement stage of development. What happens with that age group when the toddlers have this wonderful excretion of epinephrine to be able to explore, and what happens when that caregiver isn't attuned to that. And if you're raised in an alcoholic family or physically abusive family, mentally abusive family, put it this way, Mike, I really like the way you put that. And the question is not what's wrong with you, it's what happened to you. That's the question.
Or wasn't done for you, like that. What you didn't get as well.
Yeah.
Well, Dr. Cassell, what would you say, have you noticed in the brain, or have you even researched this area of developmental trauma, addiction and the receptors, and how that all plays together with mental illness and substance use disorders?
Yeah, I'll try not to make this too long, but I could go on and on about this. So I started my research thinking, like I think many people at the turn of the last century, that it was going to be pretty much biology causing behavior, that there would be some errant molecule or receptor or pathway that explained addiction or narcissism or depression. And, since that time, we completed the Human Genome Project, which was really a naive project at the time. We were all thinking, this is going to solve it. We'll take a bunch of narcissists and a bunch of people who are very, other-oriented, and we'll just compare their DNA or compare their brain pathways and see the differences. And I was one of those who was just pretty gung-ho about that. And what's been so interesting over the last 20 years, or maybe 25, is that almost nothing is explained by biology alone. So I would add to Michael and Raquel suggest that some people are more vulnerable than others to developing any of these behavioral disorders by heritable genetic and epigenetic maybe influences, but that the biggest catalyst is probably developmental inputs, either things that enhance or suppress these tendencies. And so I think in a way, after all this time in the basement of a biology building, that the low-hanging fruit is probably in family systems and in interventions early to help provide everybody involved with the support and the guidance that would benefit, all of us. So, I do think there's some biological tendencies, but these are only tendencies. And so, no, there's certainly no, bad receptor that we know of. And I think people have checked. But it's also important to know that the brain, I think people probably realize that, but the brain is changed by experience, probably more than anything else, good and bad experience. And developmental perturbations or influences are the ones that have the most lasting effect because the brain is being organized during development. So, I now think, as I said yesterday, that addiction is largely a developmental disorder. And I suppose that, that's what we think about narcissism also.
Terrific. Do we have another? Go ahead, Mike. Sorry.
Raquel, you spoke about you went back as young as 15 months. What is the time frame? This is to all of you, but what is the time frame developmentally that we have to work with, or to make improvements, correct things? Or is it a case of once the damage is done, it's done?
No, and I'm sure Dr. Vassell can speak to this. I mean, the neuroplasticity of the brain, we used to think that you were born with one particular attachment pattern and that was it, you're sunk. And what you just beautifully said is the brain does change with our circumstances and with relationships. So I know that when I ran an agency for kids from alcoholic homes, the age that children made decisions, the research said then, between about before fourth grade. You had to get them before fourth grade in order to do some early intervention with them. Ideally, I suppose it would be out of the womb. I'm going to leave it to
I'd say even before. Michael, did I just cut you off or no? Are you when you're an infant, a newborn, their brain is a quarter the size of an adult brain. So 25%, but by age 3, it's 90%. So between birth and age 3, like by the time they turn 3, it's basically, become an adult brain. So I think the earlier the better, and probably the most potent time is between birth and age 3, according to the neuroscience.
That's what I was looking for. Thank you.
Sorry about that.
No.
Now, we talk a lot about, and you were speaking about neuroplasticity. We used to think that the brain was fully developed at 18, and now we're saying, 25? And with the prefrontal cortex being the last part, is that accurate?
Yes.
But that continues beyond age 25 in terms of how we experience the world. Is that?
Well, our brain is always plastic. The day you die, you could be learning new things. It's just much more plastic at sometimes than others. And so before age 25, the pathways and the circuits are being laid out. After that, you can do little changes. But this is the reason, for instance, it's so much easier to learn French, before you're 25. And it's easier to learn anything, including addiction or mistrust or, anxiety. So this is a really, probably an unparalleled time for setting up the adult behaviors. And it makes sense from an evolutionary perspective too, because, you can't wait forever. So you kind of organize everything. And that is largely according to some genetic predispositions, but mostly what the experiences are. Erickson, the old psychologist, used to talk about this all the time. There's certain things that have to happen at certain times. Maybe Raquel talked about this, but early babies need to learn that the world is trustworthy. And they get that if their caregivers are appropriate and responsive. It seems sort of obvious, but a lot of caregivers are not appropriate or responsive, partly because their parents weren't either. And so, if you don't get that early on, it's so challenging, I think, to overcome it, because the brain is it's sort of like language. There's certain times in your life where particular experiences have a really strong influence. And if you are deprived of language, let's say, until you're 8, you hear no language, and then you start hearing it at 8, you'll never speak normally or hear normally, because the critical period for language development is before that. So you might be able to get some words out, but you won't, be able to do so normally.
I mean, I would like to add to that, though, however, indeed, that if you don't get it, if you don't get it from your parents, resiliency speaks to the fact that you can get it from other sources, which is the beauty of the early intervention, and organizing with schools and neighbors. I mean, when we're talking about infancy, that's tough, because then that proprioceptive feeling of non-attachment is very difficult. But, I believe that I don't know if you've heard the term post-traumatic growth, about how people make meaning and the resiliency involved in new connections, which is the beauty of treatment and recovery too.
I completely agree, and I'm very excited about which is something you probably know more about than I do. But just as the adolescent period, for instance, is a real vulnerable time for developing addictions, it's also a really unique time for recovery and for making changes. So I think I completely and wholeheartely concur that if we can, it's a great opportunity for doing interventions. And certainly in my case, I think, I was a pretty big mess, but I was able to get help before I had that, 25 or 26. So I think those last few years of neural plasticity contributed to the resiliency that, I eventually was able to take advantage of.
I think it's also important too to consider, like with trauma integrated treatment, that idea of safety first and kind of managing that limbic system that's out of control, and that, we can talk about plasticity, but I always think about the downregulation of the cortical function as we're getting more and more anxious, and like that seems to be the biggest obstacle for our young guys that are in our treatment program, in that they can learn new material, but they have a hard time pulling it and using it in the real world as anxiety is higher and as their kind of limbic response is happening. I just, as you were talking, I was thinking there are just so many epigenetic and environmental factors that play into whether that plasticity happens or not, or plasticity is there, but whether that learning is going to happen or not.
We have a question from one of our Facebook viewers. How prevalent are groups working with this information in daycare centers?
Boy, I
have no idea.
I don't either.
Care centers. I mean, that would be fabulous. I know way back when we implemented group in elementary schools, and did prevention work with kids, particularly those who are most vulnerable. And but I don't know about daycare centers. Anybody have any knowledge?
Yeah, it's a great question. I don't know.
I know that daycare, at least in the U.S., is grossly underfunded, considering the returns on that investment. So we are really making bad investments, but I think it's a great idea, terrific idea. And definitely the neuroscience supports the idea that the earlier and the better quality the intervention, the more effective it will be.
We have another question. Have we frozen? Karen, another Facebook person asked treatment suggestions for the client who refuses to do any service work. I think this is for Raquel. Until my community gives back what I deserve, and only when I feel nurtured, I will consider giving back.
Yeah. You know, I think part of working with an addict is what I call undoing aloneness. You've probably heard this, that the opposite of addiction isn't sobriety, it's connection.
Mm-hmm.
And so when someone poses that question, can you put that question up again so I can see it again? There you go. What strikes me is only when I feel nurtured, that would be a therapeutic moment for me to go into. So what is that for you, feeling nurtured? And what would that be like? And where do you feel it in your body? And have you ever experienced it? And do you feel connected to me? So rather than, that would be one approach, and that's probably where I would go with it. I mean, I believe in using creativity, and I call it creative manipulation, perhaps. If you could go the route of, the community needs you, you have such good expertise, if it was a narcissist, and the advantages of getting out in the community and perhaps the mystery of what you could get back. But I think mostly I would go with, what would make you feel nurtured and what is that like for you? That's probably where I'd go with this.
Terrific.
I really like that answer, Raquel. I think that as a somatic therapist, that idea of working in the present moment, working, and I think that nurturance is a great focus, but sort of pendulating into kind of that cognitive work, into emotional work, and then into the body stuff, the somatic therapy, and then back into the other discussion would be really, really useful. I can't remember who wrote the book, but there was a book on avoidant attachment that really talked about that effort to push the therapist and push the community and push the therapy away, and that really present-centered work. And I've found it to be really, really effective.
Thanks, Mike. Do we have another question from the audience?
I have one that came in via text. I'm thinking this would be best for you, Judith. It's a marijuana question. With legalized marijuana being touted as treatment for anxiety, this is coming from a friend on the East Coast whose son has had terrible anxiety as far as they're concerned as a result of smoking marijuana. Could you address that?
Yes, that person's experience is much more the norm. So if there's no evidence that marijuana or THC is a treatment for anxiety, no medical doctor supports that. So that is, kind of what people talk about on the street, but there's no evidence for it. So I guess people talk about a lot of things. In fact, if there's any evidence at all, it is that chronic smoking will lead to anxiety. And speaking of young people and resilience in this developmental period, I hear from a lot of kids who were given marijuana with a medical card, 5 or 10 years ago, maybe not quite 10, but 7 years ago, because they were anxious or depressed, and their anxiety and depression is worse now than ever. So they're, living in their parents' basements and trying to figure out, why they don't want to live, and they have, little hope and lots of anxiety. So marijuana is such an interesting drug because some people get more anxious to begin with, and some people experience a reduction in anxiety when they smoke. But whatever the if you're anxious to begin with, it's only likely to sensitize and get worse and maybe lead to paranoia and possibly psychosis. If you're somebody who for whom an acute exposure to marijuana reduces anxiety, that effect will lessen over time. So the more you use, the more that ability of marijuana to do that, or THC to do that, is reduced. So in fact, it completely backfires. Yeah, the best treatments for anxiety that I know of are behavioral, because all the drugs end up producing anxiety. Benzodiazepines make you eventually more anxious, especially if you don't have them. Alcohol obviously is used to reduce anxiety, and those people are often anxious. In fact, those two disorders, alcoholism and anxiety disorders, go together. So, it's great that the person notices this. I wish that we could get that information out, because I was just on another panel about a week ago with some psychiatrist from Yale, and he said there's no evidence whatsoever that it helps with anxiety. It makes anxiety worse. So
That's so interesting. Not to harp on the whole neurological of marijuana, but why is it that we've had a number of high school students that have gone on to college, avid marijuana users, and they have developed schizophrenia? And so obviously something in the brain has switched. I've never heard of a cure for schizophrenia. So is there no way to turn that brain mechanism back? Is it once it's turned on, it can never turn off again? What's your feeling on that, or your thoughts?
Yeah, so others might have views on that, but I've thought about it a lot. And there was a paper about a year and a half ago in The Lancet suggesting that 40% of the new diagnoses of schizophrenia, so everybody who's diagnosed with schizophrenia in the world today, 40% of those can be attributable to smoking high potency weed. And what is going on, it's kind of a confusing thing. So we don't think that marijuana causes schizophrenia. It looks like schizophrenia, funny enough, is a developmental disorder with a genetic predisposition, just like we've been saying, and that what precipitates it, so what makes it show up, is stress often. And smoking high potency weed, especially on a regular basis, will alter your perception of reality to such a degree, especially in these vulnerable people, that it will be a cognitive and emotional stressor. So much so that they can't kind of overcome it, because their conscious control is being overtaken by the effects of the drug. So I'm making this complicated, but so schizophrenia tendencies are latent in probably between 1% and 4% of the population. And for some of those, if they have a safe, loving home and low stress, you'll never know it. Others with either difficult home life and or drugs like marijuana or psychedelics can bring it on. And so and in some of those cases, stopping can reverse it, but in a significant number of cases, the psychotic state that's brought on by a drug, marijuana, for instance, isn't reversed over time. So even if you stop smoking, you kind of can't go back. And it's, really tragic. And just kind of as an aside, if you don't mind, but, since we're legalizing it so much, this is really kind of not a very kind response of society, because there's a significant number of people who are vulnerable to these disorders who are going to be really impaired if they use. And, I think it's, in a way, it's almost like having people who need some help getting up the stairs or something. And we just say, well, that's their tough luck. They can't go in the building, or too bad if they're vulnerable like this, they really shouldn't have smoked. But, if it's so widespread, I think it's very hard, especially for 16, 17, 18-year-olds who are trying to fit in. So did I answer that, or was it too much?
Yeah, thank you.
Very much. You also brought something up that's been very talked about a lot over the last few years, psychedelic drugs. Is it accurate that back in the 50s and 60s, LSD they thought might be used for therapeutic reasons? Now you see, or I've read a fair amount about, is it MDMA? That's ecstasy, essentially. How do you all feel about that? Is there legitimate treatment value there, or is it another situation like you just described with marijuana, Judith?
Does anybody else want to jump in before I say anything?
Dr. Barnes? We can't hear you.
There is research, the MAT study that was done at University of South Carolina Medical Center, and it's been throughout the country. And certainly there was a fairly substantial MAT process at the University of Colorado with some folks that I work with. And many of them speak really highly of it, that they saw some pretty significant progress. I had a mutual client who was in that study, and I asked him how that worked. And he said it was an awesome study. He said it didn't help my PTSD, but I really liked using the MDMA, and which, clearly, so the jury's really not out, but there are certainly some people who have some pretty strong beliefs that it's going to be an answer.
Yeah, it has gotten a lot more press recently, and but Judith, I was wondering if it might be what Mike just said. The guy enjoyed it while he was doing the MDMA. The kid who's smoking weed, who feels better for an hour because he's high, but ultimately the anxiety gets worse. How do you feel in terms of MDMA?
Yeah, I definitely put MDMA in the category of drugs like cocaine and amphetamine, and it is more a stimulant than a psychedelic. It's a changes your perception of social interactions, but marijuana and the psychedelics, the classic psychedelics like LSD, mescaline, psilocybin, DMT, or ayahuasca, those drugs are a totally different category pharmacologically. MDMA is damaging to the brain. It causes depression. Now, if you are struggling with PTSD and you're so traumatized that nothing has been able to help you, maybe they need to get to Raquel or somebody or Michael. But if we don't have great options, there is a group using MDMA, and I think it does temporarily make you feel better. I don't think the data is that strong. On the other hand, the psychedelics like LSD and psilocybin and all of those were used in the 50s and 60s, and that's coming back. So there are good, well-controlled studies happening at Johns Hopkins, at NYU, at the University College of London. So great schools where people are put into kind of like it's a clinic and it's a laboratory, but it looks like a really nice hotel with good speakers in your room, and they have guides who are trained clinicians who help you through your trip. And this is, in some studies, I would say the data are pretty compelling that by giving people insight into their neuroses, which somebody else would probably speak to that better, but into their inability to kind of accept the truth about themselves. So for instance, one group of studies is for people who have a terminal illness, who just are falling apart, kind of can't come to terms with that. They report after this experience 1 or 2 or 3 times that they are much more at peace. Now, the truth about marijuana catalyzing schizophrenia is also true for the psychedelics. So in vulnerable people who are already at risk for this sort of breaking from reality, this can be too much because it is stressful. So, I think it's a case-by-case basis. I'm really always for the research, and I think the data, will help us in the long run, but I wouldn't suggest, going out and buying something on the street to try to help your PTSD.
Quick follow-up: how do the clinicians go about screening then, to screen out the people that might have a potentially negative?
Yeah, that is a great question that I don't know the answer to. I think they look for family history, which is a big predictor of psychosis, which is fairly rare. And I also think they look for sort of to rule out people who are just need to grow up a little bit and go for people who are really struggling. But I use those drugs in, when I was using drugs. And I think in some ways the insights I got helped my recovery because, and these, by the way, I should say that the psychedelics we're talking about are not addictive drugs, according to most pharmacologists, including me. They don't release dopamine in this reward pathway. They're not self-administered by other animals. I think they're really potent and potentially therapeutic, but also potentially harmful. So we have to be kind of careful.
So, Dr. Barnes and Raquel, can you talk a little bit about the family dynamics with addiction, narcissism, and trauma? I know that's pretty broad, but pick on any piece of that and what you might have to say to family members.
I can speak a little bit to the trauma piece, but I'm really curious about the narcissist piece, to be quite honest. I think the piece that gets missed, and we did a study when I was at Cedar and really, looked at how do families envision like living with an active addict, and 95% of the family members that we studied said that they strongly agreed or they agreed that living with an active addicted individual is a traumatizing event. And I think we miss the fact that when the DSM-5 says that we get traumatized by experiencing an event, witnessing an event, or having someone that we care about have significant traumatic events, as well as the new fourth aspect of the criteria that kind of working in an environment where they're constantly reminded that families are, I think, far more traumatized than the clients are in many cases. And I think that the studies that we did back in the 90s and really looking at families in hospital settings was that they had the exact same symptoms of post-traumatic stress disorder, that the longer they stayed in the fight or flight, that they sort of shifted away from their goals and values to be much more about safety and security. And that's where we began to see, like, in my mind, enabling and caretaking and that kind of thing is really, when you ask anyone from a family that does it, basically talks about their kind of activation of the sympathetic nervous system, that I think those are really trauma responses for many family members. And so when we talk about that, I really think that when I work with families, I usually start by talking about trauma in general and the trauma of their client. And they're very interested in that because they really want to be of service and to help and to do everything they can to help their loved one. But over the course of time, it's amazing how many family members will say to me, well, I kind of have those symptoms too. And so I think that, my primary approach is that, trauma looks like a really linear process. An event happens and we have symptoms. But if you look at van der Kolk's work and how memory is impacted by the interaction of those who receive the story when you tell it, that I think it's much more systemic and much more recursive than we think. And so what I would tell family is clearly that your loved one's addiction may be very closely tied or co-occurring with their history of trauma, but the family member's trauma of experiencing the things that they've done with the loved one actually may be doing more to reinforce the kind of systemic interaction and than not. So
That's great.
I mean, I think what Mike said is absolutely spot on in terms of the trauma. think, when I say addiction is a narcissistic phenomenon, they don't call us king and queen babies for nothing, right? I think, the whole family structure is to support the alcoholic, to either hide it, enable it, and it's unconscionable what I've seen through the years in treatment, and in terms of not including family and not including young members of the family as well. For a narcissistic client, it's about teaching the family how to take care of themselves, about what healthy boundaries are. And they are going to feel very disloyal in doing that. And there's so many factors to that. If there's violence in the family, what's a safety plan for you, and how can you stand up for yourself when there's, violence looming over. But I agree with Mike 100% that they do take on characteristics. And if we can, if they can both have compassion and understand the trauma, compassion for themselves and the addict, and develop a safety plan for themselves and get ongoing help. One family program isn't going to do it in treatment. And I think that's what we're realizing, that the reverberating effect of those growing up in these families is devastating and continues the destructive path of addiction.
I think that's well said. And I think Dr. Barnes alluded to, families needing much more time and much more care than they would in a treatment program with a family program. Mike, you want to speak to that again?
Well, that's one of the things I started my presentation with the story of finding a paper that I wrote in 1991 about maybe it's time for a systemic paradigm shift in treatment, that we begin to look much more at the relationships within the family. And I found that paper just a couple months ago and realized that it was written 30 years ago and nothing's really changed in the 30 years. There's a lot changed for our work with the client, with neuroscience and kind of medication-assisted therapies and all those things. But there's really, it's so refreshing to hear Raquel talk about, the work that she's doing, and that it's my opinion that when we separate that client out from the family and send them to treatment, that in essence, we're kind of creating this sort of secret system, and that people are working with the family to do certain things, and we're working with the client to do other things. And while we talk about it, the client feels less a part of the family in the end than they did at the beginning of treatment. And so that's why I really started looking at that chronic disease model and looking at what are they doing in the medical environment. And, they see the family as every bit as important to the treatment as the client with the chronic disease. So, that's, if we don't start treating the family, our, improving outcomes from addiction are going to happen when we start including families in the treatment process.
Okay, I have a question here. Do you feel, the papers are flooded with opiate addiction, the rising numbers, especially during COVID this year. And this is a question for all of you. Do you feel hopeful about our future with addiction? What are your thoughts on that? Oh, Judy.
Sorry, I was trying not to make extra noise. I think after listening to Raquel and Michael, I feel hopeful, because just to recognize and treat the system that's involved, I think is really hopeful. I think it is a very hard time for all kinds of psychological illnesses. I think the rates of depression and anxiety and substance use, as far as we know, are dramatically increasing since, just a year ago. And they were high already, but now they're pretty epidemic, or we have, this pandemic also, I guess, the mental illness pandemic. But sometimes I think that it has to get worse before it gets better. And one of the things that it's easy to see is that we need each other, and we need connections, and we need, sort of attention and care. And I think it's, we might have been able to skim through that with a 5-day detox and a pat on the back before, but it's pretty dang clear that this, psychological struggles require a much more comprehensive and thoughtful response. So I think we're seeing the lack of that.
Raquel?
Well, no, when you said that, I was thinking back to the debates. We do really need some strong leadership in this country that really gets the place we're in terms of addiction. And like Judith, I feel optimistic when I take part in these and listen to other professionals and what they're doing. I think the combination of the research, the scientific-based research on trauma and what's happening with the brain, and that makes me hopeful that there will be a day when we will know more about what really causes this, and be more effective on how to treat this. I am convinced that will happen. I pray it's in my lifetime. Not sure that will be. So right now it's mixed. I don't see any short-term, there's no short-term optimism right now for me, but long-term, I do feel optimistic.
Terrific. Dr. Barnes?
I have to say, I think we live in a traumatized society, and I think that if you just look at the growth that's happening, so let me just start. I'm hopeful. I think there's so many really interesting things, the work that Judith is doing, and the neuroscience approach. I think this is going to sound, I think the medical advancements are phenomenal, but I think it can't stop there. If we really understand the epigenetic influence, the work with the family is really every bit as important. And I don't think we support that from a payment standpoint. I don't think treatment centers are able to do the kind of work that we would love to do with families, and that we have to figure that out. But I agree that we have to be, Mnuchin used to talk about we need to create a crisis for the family in order to get them to take the change process serious. And I think it's the same for our field, and I think it's the same for our society.
Mike Connolly, do you have any thoughts on that?
You caught me off guard.
I did, I know, sorry. That's like the teacher in class who calls on the student.
I'm a moderator. I don't at the moment. I'll
Okay, that's fine. Any last comments from any of you before we close out today's panel discussion?
I just want to say something to you, Liz, and your organization. I'm very impressed with what you are doing in your community. Be honest, I had not heard of A Way Out before, but my association with you and looking up really the advances you've done in your community and the broad scope of what you take care of, I was impressed.
Oh, thank you.
What?
Go ahead.
I was going to say the same thing, that as a provider on the western slope of Colorado, and having had the chance to work with you and clients at Foundry and at Cedar, that you have supported, that it just needs to be commended. You guys do a phenomenal job.
I'll just chime in and say that I agree. There's always hope, always. And with the kind of excellent growth in treatment of the family and the whole person, I think there's a lot of reasons to look forward, and I appreciate A Way Out also.
Well, I have to acknowledge our board of directors who really have made this happen. We don't have a screenshot of them, but we have 9 directors who really put their heart and soul to our organization, and it's why we're successful. And if you're watching this and you just feel like writing a check, go ahead. You can visit us on our website, www.awayout.org. And I just want to thank our esteemed, talented professionals, Raquel Lerner, Dr. Judy Grissel, Dr. Mike Barnes, for your presentations this week and helping all of us learn how to better help those who are suffering from a substance use disorder. Many, many thanks.
Thank you so much.
Thank you.
All of you. Hopefully we can be together in person, and
In
everyone will be a
2021.
little bit healthier because of it.
Yeah.
Maybe in Antigua.
Yeah, maybe in Antigua.
Yeah, that would be awesome.
An excellent idea.
No, Aspen's nice too. Anyway, probably not central Pennsylvania, although it's nice.
Yeah, I bet your color.
Today it's beautiful.
Hey, I grew up in central Pennsylvania, so
It's a gorgeous day today. The leaves are changing and lots of good things.
I'm
Terrific.
going to be in Minnesota. So
Mm,
same, the leaves are changing, but I'd rather be in Antigua right now.
mhm.
All right. Thank you, listeners, so much. Thank you for your participation.
everyone.
If you have any questions, director@awayout.org. Thank you.